Welcome back to the American College of Surgeons Bulletin Brief from the Frontline Surgeons' Voices. With me today is Professor Maria Oquendo. Professor Oquendo is the Ruth Meltzer Professor of Psychiatry and Chair of Psychiatry at the Perelman School of Medicine at the University of Pennsylvania and Psychiatrist in Chief at the University of Pennsylvania Health System. Welcome, Dr. Oquendo.
Thank you very much. It's a pleasure to be here.
Well, thanks very much. And I'm delighted that my fellow leader on the Board of Regents, our chair, Dr. Scott Levin, connected us because you've got a lot of interesting and important things for us to hear for Suicide Prevention Month. I'd like to start out the conversation if you could tell us a little bit about the demographics and what's been going on in terms of any trends.
One of the things that has been alarming over the last 20 or so years, 30 years, is the increasing rate of suicide in the population, despite a very focused effort on trying to decrease it. So since 1999, the suicide rate has been going up on a regular basis, with the exception of the last year and a half. It appears that during COVID, rather than going up, despite the fact that mental health issues are on the rise and people are reporting a lot more anxiety and depression, the suicide rates have actually taken a dip. And suicidologists will tell you that that was sort of to be expected. And we don't really know why suicide rates go down during major disasters like a pandemic. But some of the hypotheses have to do with the experience of the individual who's suicidal in the context of a major external threat. One idea is that perhaps those individuals start to live somewhat more outside of their own head, if you will, or less involved with their own worries and concerns, and might turn externally somewhat more. Another hypothesis is about whether there's some sort of solidarity, which we all experience often when there's a major disaster. These things bring out a sense of community because we're all in this together fighting it. And so it may also lead to suicidal individuals feeling more integrated into something larger than themselves.
Thanks. That's very interesting. I'd heard, at least in the lay press, some different statistics about murder that we heard, and I don't know. It's not necessarily suicide prevention awareness that we're discussing, but are you aware of any statistics for murders during COVID?
I can tell you that in many of the major cities, there's been a significant rise in gun violence. Again, the reasons for that are not exactly clear, and whether it has to do with isolation and consequent increased drug use, for example, that could be one explanation, but I'm not sure that we really understand it at this point. Interestingly, many individuals, but certainly not all, who struggle with suicidal ideas and attempts also have a tendency towards aggression and impulsivity. Again, this is a fraction of them, but those two things are unfortunately not completely unrelated.
Yeah, interesting though, the differences with homicide and suicide during the pandemic. But the one theme that may be common that you mentioned, drugs and alcohol. And I'm wondering, as we think about our profession and surgeons, if you could tell us a little bit about rates of suicide relative to medical specialties.
The rates of suicide amongst physicians in general are higher than those of the general population. And there are some specialties that are at highest risk. Surgeons is one, anesthesiologists is another. I think that the role of alcohol and major mood disorders is really, really essential, which is why the efforts that we all make to identify individuals who are struggling with substance use in the workplace can be very life-saving, not only because substance use in of itself is extremely deleterious to health, but also because oftentimes as people lose control over their life and start having problems functioning, they also can become suicidal.
Interesting. We have a global audience. The American College of Surgeons represents the House of Surgery really throughout the world, and people will be accessing our conversation in all different continents. Are you aware of the statistics in other countries? Are they the same, that the rates are higher in physicians, or that the rates went down during COVID-19? I'm just curious to get a kind of global perspective.
Some of the global data suggests that there was a decrease globally in suicide rates across the world. And of course, naturally, most of the data comes from high income countries. So we know much less about what's happening in low and middle income countries. But certainly in the high income countries, we've observed the same phenomena. And the issue around physicians being at greater risk is something that is mostly published about in, again, higher income countries. And so it's a little difficult to generalize to the entire globe, but certainly the US and Western Europe observe these.
So as surgeons, we look at things undoubtedly in a kind of myopic way in terms of here's a problem and we fix it with an operation. But of course, it's essential that we're cognizant not only of the whole patient, but also of our colleagues with whom we're working. So what are some tips you can give us as we're with our patients and as we're with our colleagues? Perhaps things we can look for and warning signs. It is Suicide Prevention Month, so if we can contribute to that overall effort, that would be highly beneficial.
Perhaps the most commonly associated condition with suicidal behavior is major depression, which is, as you know, extremely common. The estimates are, at least in the US, that about 15% of women will have a major depression at some point in their lifetime, and about 10%, of course, this varies over time, but about 10% of men. We also see that the younger generation may be having a cohort effect when it comes to mood and anxiety disorders. And those are really important signals for us to pick up on. I really think that the screening tools that are being used in many health systems can be extremely useful for detecting individuals at risk. And that's important because today we do fortunately have multiple interventions that can be life-saving and preventive. And so that makes screening and identification absolutely essential.
Great, and that gets to the next point, which I'd like to discuss, which are the specifics of some of those tools and techniques so that we're aware of them. And maybe there are some that we can even employ ourselves as surgeons, whether that is some type of peer support or development of wellness programs or encouraging referrals, whatever it happens to be. Perhaps you could enumerate.
For suicide prevention per se, the interventions that have been developed in the psychotherapeutic realm, there is an intervention called the safety planning intervention, which was developed to use in clinical settings, mostly emergency departments. And it's actually a step-by-step protocol that the clinician develops with the patient on steps to take when they start feeling suicidal. And this intervention has been shown to reduce suicide attempts by 45% in the subsequent year. Another intervention is the collaborative management for suicidality. And one of the things that's interesting about both of these interventions is that they're interventions that are conducted in collaboration with the patient, where the patient is engaged in problem solving. We also do have some pharmacologic approaches today. For example, clozapine for individuals who have severe mental illness can be life-saving, and certainly it's even FDA approved for suicidal patients with schizophrenia who are at very high risk, incidentally. And there's more recently ketamine, which has been tested in IV form and shown to decrease suicidal ideation. And the data on that is still developing because most of the studies, all of the studies have been powered only to look at changes in suicidal ideation, which is very different from behavior, of course.
Thanks very much. Before we end, I'd like to give you the opportunity to say anything else you might like to say, realizing that most of the people watching are surgeons, but not all.
For physicians in general, I think that we tend to be very slow to recognize when we have ourselves a condition that needs attention. And I think that being attentive to that and being responsive when others approach us and ask how we're doing or that we seem different or whatever, I think can be really, really important. And I don't think it's easy for physicians to accept help for mental health conditions. A lot of this is historical and has to do with the fact that in some states, for example, you had to answer questions about ever having a mental health condition. That makes it very difficult to obtain help if you worry that you have to disclose it later. But most state boards have now changed that, and I think that we're in a much better place.
I'm sure there's a lot more information which should be shared with our viewers and listeners about suicide prevention. Perhaps you could suggest one or more resources.
I would highly recommend the American Foundation for Suicide Prevention's website. They have a wealth of not only data, but also clips and ways of accessing help directly, and you can refer patients to it. They're very helpful in terms of connecting individuals to help, and they also support families who are survivors of suicides, which of course can be very catastrophic for families.
Well, thank you very much. I greatly appreciate your insights and reflections today. I've enjoyed our time together and wish you continued health and success.
Thank you very much. Really appreciate it.